Hello and welcome to the Patients Engage podcast series, Lived and Leading Voices for Better Healthcare, where we feature persons with lived experience of a condition or a disability and how they are channeling their learnings and experiences into improving healthcare. They could be providing peer support or could be advocating for changes in the health system. Patients Engage is a platform that empowers people with chronic conditions and disabilities to engage better with their health and make informed decisions. We also advocate for more meaningful involvement of persons living with long-term conditions in health system decision making. I'm Aparna Mittal from Patients Engage, and today I'm speaking with Ms. Nandita Venkatesan and Ms. Ashna Ashesh, both of who are TB survivors, patient advocates, and more in episode 11 of the Lived and Leading Voices for Better Healthcare, titled Ending TB Together, Power of the Community. Nandita is a health policy professional, a data journalist, and was listed among Time magazine's 100 Next Leaders. She's recognized for her work in advancing health equity by working to make essential generic MDR TB drugs more accessible in India and globally. She fought an agonizing battle against 2 rounds of TB at a young age and lost much of her hearing at 24 years due to the treatment. Nandita has strategized and led high-level advocacy and community engagement initiatives to bring patient voices to the policy table, including addressing the 2018 United Nations General Assembly. She's been a member of the WHO Civil Society Task Force on Tuberculosis and the Lancet Commission on TB. Ashna Ashesh is a lawyer, public health professional, and an MDR TB survivor. Ashna is a member of the WHO CSTF TB, which is a Civil Society Task Force for TB, and vice chair of the WHO Southeast Asia Regional Technical Advisory Group for TB. She's associated with SATB, Survivors Against TB, a community collective that advocates for persons and community-centered TB care. She served as a subject expert and member of subcommittee of experts for gender responsive and LGBTQIA plus affirmative action in TB under the Central TB Division, Ministry of Health and Family Welfare in India. Her work in TB focuses on a rights-based approach to care, community engagement, social protection, mental health, gender responsive care, and equitable access. The TB problem continues to grow, or not grow, but exist. We still have 10.7 million new cases globally in the last couple of years each. India accounts for more than 1/4 of this burden, and there were about 3.2 lakh deaths, or 300,000 deaths in India due to TB in 2023, based on the last data that we have. March 24th is World TB Day, and the theme this year is Yes, We Can End TB. It's a bold call to action and a message of hope that ending TB is not just aspirational, it is achievable. Our discussion today will highlight the role and power of the community to make this happen. So let's get started. Welcome, Nandita and Ashna. So it would be great if you could, both of you can give a quick recap of your journey with tuberculosis and the key challenges of your journey. So maybe, Nandita, we'll start with you.
Hi, thank you. Thank you, Aparna. Am I audible?
Yes, you are.
Okay. Thank you. Thank you for having me. And it's wonderful to be a part of this discussion along with Ashna, another wonderful and a very strong TB survivor herself. So I had like a pretty traumatic battle against this disease at a very young age. I had this disease twice in my life. I was first about 17 years. I was technically a minor when I had contracted this disease. I was 17 years and I had just started my college in Mumbai. And I had contracted intestinal TB at the age of 17, and this was 2007. And back then, intestinal TB or even TB was not very known. It was mostly spoken about in very hushed tones and silences. But intestinal TB was not at all known, because TB was generally seen as something that, it spreads in your lungs, and you contract it through the air. So non-contagious forms of the disease were not really known at that time. So definitely because of that, there was this added, sort of misinformation and also stigma that surrounds the disease even today. So I had contracted the disease at that time, and I had taken treatment for about a year. And it was during my college time, so naturally some part of my college life was affected and impacted because of the disease. But overall, it was fine, because technically I didn't have to go through the horrible things that I went through the second time. So I, of course, went on to, I finished my graduation, and then I went on to do my master's. I had moved from Mumbai to Delhi, and I had pursued my master's. And then after that, about a year after I'd finished my master's, about a year or a little more than that, after I'd completed my master's, I was told that TB has sort of resurfaced into my life once again. And this time again, it was in the intestine. It was in the same portion, technically the large intestine. And we were sort of told that, that if we will put you on the medications, and if your situation and your condition does not improve, we will have to undergo a surgery. And it was supposed to be a matter of just one surgery, and sort of a few days of hospitalization, and then I'm back to normal life. And that is how I had seen the picture as, but the picture turned out to be completely different. I was hospitalized for nearly 3 months, close to 90 days, and the bacteria spread from the intestine, and it started spreading into other organs, and it took a lot of effort to sort of bring it under control, in the sense that apart from a very long period of hospitalization, I also underwent about 6 surgeries in my stomach. And then again, so it really sort of spiraled out of control, in short. And just after this whole thing, I ended up losing my hearing because of kanamycin injections that were given to me. So it just sort of happened very at the snap of a finger, where I ended up losing my hearing in sleep. So something that just happened out of the blue, but for a medication that is known to be a very important medication, that's known to be a powerful medication. So the situation just sort of spiraled out of control. I ended up losing my hearing. It took a big toll on my mental health as well, a very, very deep toll on my mental health as well after that. So took about 4 years, 4 years of my life was sort of consumed because of this disease. But I'm just thankful that I think it's a signal. After what I've come out of it, I feel it's a signal that I need to uh, become maybe a voice of change, and maybe sort of help, if I can help others in dealing with this very grievous disease, then why not?
Thanks, Nandita. Very quickly, couple of quick questions. You said you got it again. Were you monitoring for symptoms or for TB, or did the same symptoms come back? And two, were you aware of the potential side effects of the treatment before you got
So
treated?
definitely, I think to answer your question, after I had finished the first round of the disease, I was completely cured, in the sense that I had taken the medication, and I was given a sort of a go ahead by my physician as well to move cities. And it was, I was sort of given a complete go ahead, that that you're done with the disease,
Right.
and you can go ahead and move ahead in your life. So as such, your mental monitoring does happen. I think Ashna would be able to relate to that. Some sort of mental monitoring does happen, in the sense that you're watchful about your food, you're watchful about the water, you're watchful about the things like that. So definitely that sort of mental calculation is something that I do even today. It's been like 10 years, but that mental calculation never goes away, that okay, I need to be extra careful. So that was there even back then. So there was
Right.
never really reason as such as to, there's no explanation as to why I got it back again, or, why this happened. So I don't think there was any explanation. I guess it's in the air, I guess, and it literally can impact anyone. And could I get your second
Your
question?
second question, were you aware of the side effect of that treatment?
No,
Of
no,
loss of hearing?
about hearing loss, I was not aware of the side effect. We were not told about the side effect of hearing loss, but definitely we were informed about other side effects that the medication causes.
Right.
Because kanamycin causes a host of other side effects. Hearing loss is possibly a rare, I guess, or a very extreme side effect, so to say, the sort of complete loss of hearing. But there are other things that happen, such as, say, you get a constant sense of dizziness, you get nausea, you get a lot of vomiting symptoms, dizziness, nausea, all of this. We were definitely informed about all of that, but not about the hearing loss bit.
Thanks, Nandita. We'll move to Ashna. Ashna, if you can share your TB journey as well.
Thank you so much, Aparna, and thank you, Nandita, for sharing your story. Am I audible?
Yes, you are.
So for me, I think it started in 2017. I basically had, before 2017, I was losing a lot of weight very rapidly. And so I'd gotten some blood tests done, and it threw up things like a vitamin B12 deficiency. So I was just watching things. And then in 2017, I had a swollen lymph node right here. So above my cervical lymph node, basically above my collarbone. And because I had an interest in public health policy before I got TB, but after TB, I started working with it. So I was very watchful of things like that, and I knew that a swollen lymph node is not a good sign, especially there. So I went to the hospital. I was in Bangalore at the time. I was working at a university. I went to the hospital. They gave me an FNAC. There was mycobacterium tuberculosis. So without doing a DST, which by then was the norm, they started me on AKT. And they were watching me for like my liver tests, kidney function, all that. And in the beginning, I was doing a little okay. I'm also a caregiver, so I was taking care of my mom at that point and her attendant, who also managed to damage her knee. So I had a full-time job. I was taking care of people. I was taking my medication. And then suddenly, about like a few days into this, I started feeling really, really terrible. And the lymph node was increasing in size, which I was initially told is just an autoimmune response. But I could sense that something is off. I was sensing that it's getting worse. When I told my doctor that the initial, so this is the sensitive part of the treatment. What he did was he introduced some injectables without a DS2 again. So levoflox came in for some reason, streptomycin came in, and one of these two he was experimenting with. And I finally insisted that I'm not doing well and I'd like a second referral. And he said, why don't you wait a few more months? And I was like, no, I'm going to go somewhere else. And I went to Delhi to a family hospital, which I trusted. And there, then they did a biopsy. They did a surgical biopsy, and it was DRTB. But I was supposed to fall back to Patna because my grandfather was also unwell, and we needed long-term someplace to sort of hunker down and get through this. So 1 month of treatment, I stabilized in TB, got my grandfather stable as well. He had ascites at the time. We were both going to the same hospital. We had doctors at the same hospital. Came here through a referral. We found a really good doctor, thankfully, in Patna, and he's now taking care of 3 generations of my family through COVID. So he was fantastic. Like, I just really lucked out with him. With the doctors who diagnosed me in Delhi for the DRTB, and then with doctors who And so it was the complete opposite of the Bangalore experience, which was that I had somebody who then walked me through this. I asked him, at that time, the Bangladesh regimen had just come around. So I was like, why can't I be on that one? Why do I have to get 2 years with the injectables? Mine was amikacin. He said, because your doctor introduced levoflox without doing any kind of testing, and so it's better that you go for 2-year regimen. He treated me very much all the things we talk about in community engagement. I mean, he lives those in his practice, so he treated me very much like a care partner. I was informed about what I'm getting and why, and what are the possible side effects. And from then on, it was kind of, so this part was taken care of. But what happened again was because of the P side, my joints were kind of affected, and there's still residual damage now with the amikacin. As Nandita mentioned, kanamycin and amikacin are the same group of drugs, while they're not the same drugs. So dizziness, there was vertigo, there was nausea. Add to that the fact that after a point you run out of places to inject the person because these are intramuscular. So we tried IV hep blocks here, but those would get clotted after 4 days. So we considered femoral vein insert at some point. Thankfully, we didn't have to do that. But even with all the site rotation and all the awareness, it was 6 months of injectables is really difficult. That's really that really a period. I was also on cycloserine, so mental health issues were a big part of my treatment. I was extremely depressed. I actually got to a point where I broke down completely. I called my doctor, and he told me something that I've said this before in a few panels as well because it's stuck with me. He told me that we're going to stop your treatment under observation for 3 days, and then you're going to get right back on it with maybe a combination switch here and there wherever we can make it easier for you. And I was very alarmed because I'm like, well, you don't stop taking medication. The one thing you're told is never stop taking it. And that's true. You should never stop taking it. But this was under supervision. And he said the strangest thing to me, which is that you're not happy. And I thought I misheard him because I was clearly out of my mind. But he's like, the whole point of this treatment is to make you happy. It's your well-being. And I had never heard that or even used that as a metric of well-being myself. I was monitoring my LFT, KFT, my audiometry, my eye checkups, but not once had I considered that I'm supposed to feel better on this treatment. It was just like I had to slug it out and get through it. And this is somebody who apparently had awareness, right? So we love to say if you're aware, it's better, but it's not. I advocated for myself too late when I should have with the doctor in Bangalore. So that was my journey. And then as soon as I sort of completed treatment towards the end of it almost, I was introduced to Survivors Against TB through Saurabh Rane. And then I was introduced to the Kamina Chapal, and I wrote a piece with them and while I was on treatment, scroll on mental health and TB, because the combination of the two, there's even more silence than just around TB alone. And then I started working in TB. I finished treatment in 2019, and shortly after that, in 2019, I started working too. So that's my journey.
Right. So, can both of you, if you can also tell me a little bit about, how did you get into advocacy? I know Ashna, you just started that you got involved with the Survivors Against TB and you started writing on mental health and TB. How did you kind of say, okay, this is what I'm going to do, and this is kind of more or less not the path that you do, but this is an area of focus for you? How did you get to that thought?
So I actually started as a policy consultant. So part of my job was advocacy, but I was a senior policy analyst at a development consultancy that worked on TB. And I was also associated with Survivors Against TB and advocating for person-centered care. I think the reason that I got into it was very, very simple and not fancy at all. I'm sorry, that's my dog. He has an opinion about this, but yeah. So the reason I got into this was if I could leave, even with all the privilege I had, it was a sort of struggle to get through this. So my only goal was if I can leave this better for even one person, that's worth sort of focusing on. And till date, that remains.
Right. Thanks, Ashna. Nandita, how did you kind of, decide after the 2 rounds of TB that advocacy is the way you will, or that you will focus on advocacy as well?
I think my motive was very simple, that if there's some kind of a dent that I could make in the space in some way, in my capacity, what would it be? What would be my strengths that I could capitalize on? I would say I felt one of my strengths was the fact that I can speak well, I can communicate well. So that was one. I felt I had a sort of a big picture thinking that I always adopted. So I remember, I think one of my important catalysts I remember was the fact that when I was sort of coming out of the disease, I remember reading the newspaper one day. It was a local newspaper here, which is the Mumbai Mirror. It is a local paper that's published by the Times of India, and I read in their front pages that they had sort of spotlighted the TB issue about Mumbai receiving a big loan from the World Bank to tackle TB, and this is like about some 12 years back, 2014 or 2015. And what I remember thinking about it at that time was that whenever I was reading about this disease anywhere in any public forum, I just felt that there was a lot of it was mostly shrouded in a lot of statistics. It was mostly shrouded in a lot of numbers. But what I felt missing was the fact that the stories behind these numbers. No, the fact that these numbers also represent some real individuals and real humans. So when I would read back then, the 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 situation that I had gone through had impacted me quite a lot, and it made me think as to especially the loss of hearing, which I felt was not, I could not see anywhere written about it, or sort of spoken about anywhere. And then when I sort of realized that it's mostly sort of spoken in terms of numbers, that okay, 25 lakh Indians have TB, and then it struck me that, oh, among that 25 lakhs, there's one me as well. Why am I not seeing a more nuanced portrayal, or a nuanced discourse about this disease?
Right.
So I think that sort of started it. That was the initial sort of catalyst. But of course, it started at a very small sort of level at me. I would sort of engage with, say, I had engaged with the Rotary Club here nearby through a friend of my mother. It started off with that. Then I remember that I had given a dance performance in 2015, and I had written about it on social media. The fact that I gave a performance without actually being able to hear anything. So I think that sort of gained, I guess, a lot of traction, and that sort of spread the word, because about the fact that I had come out of this disease, because much before that I had not told anyone about it. So it was mostly, I was just sort of packaging it as I had some intestinal disease, or I had some disease. People knew something was terribly wrong with me, but what was it was not known to anyone apart from just my immediate circle. So I think that was the first time, one of the first times I actually wrote about it, and that sort of, I think, sparked the discussion around the fact that, oh, I did this performance. And I think, and then I started off with some engagements with a local Rotary Club. Then I got involved more on social media, because I felt that my communication channels were absolutely cut off because of my loss of hearing. And I sort of saw on social media about the fact that TB was actually being discussed by scientists, was actually being discussed by public health practitioners. This was not something that I knew before, because I didn't have, for example, a background in it, an education background back then. Now I do, but back then I never had that education background. So all this for me, it's sort of peeling of the layers of an onion. So I just sort of understood that, okay, there's this larger ecosystem as well that is doing a lot of talking about the disease, and why not? Why can't I not contribute?
Right, right. Thanks. Ashna, anything else that you would like to add? Um, Sorry, you're on mute.
Yeah, sure. I think Nandita covered it beautifully. I just wanted to add that this is a particularly thankless job, particularly when you survive it and then you start working in it. And then if you look at the current funding cuts, but I think while progress has been slow, the one thing that I sort of didn't want to do, and I'm sure Nandita relates to this, is sit on the sidelines and watch, because we've seen what this does up close. As I mentioned.
Sorry, Ashna, can you speak up a little bit? I think you're a little.
Yeah.
Yeah. Yes.
Yeah. So we've seen what this does up close, and so whatever we could sort of do to bring about that change. I think for me it was also that I'm a lawyer by training and a public health policy professional, and very often that is seen as a separate sort of hat, and I didn't see that as separate, because both of these things, public policy and law, are designed to make people's lives easier.
Right.
So for me, I think it was just channeling that into how do I sort of get the affected community lived experience informing the policy that we're shaping up, the strategy that we're shaping up, the advocacy that we're shaping up, and more about listening to people, because again, my experience is just my experience. There are there are as many experiences of TB as there are people with TB. As Nandita said, they're not numbers; these are actual people with lives and hopes and dreams and aspirations and this terrible thing that happens to them. Yeah, I think just sort of bearing that in mind, that I'm one voice, and while I can try to be as representative and inclusive as possible, I need to sort of listen, because we're not sort of here to empower anybody. It's always my pet peeve when people say we want to empower communities, because you've already privileged yourself above them. So
Right.
listening and learning and sort of working together to see if we can do with TB what we did with smallpox. We did it once, we did it with polio, and hopefully we do it for TB in our lifetimes.
Right. Thanks. So, can both of you share one of the advocacy efforts that you were or are involved with, and what was the challenge that you were working around, and how did you make it happen? Nandita, I'll start with you.
I think I'll start. There were one or two of them, but I think I'll start with the one that I did when I got a chance to address at the high level meeting in 2018. So it was the first time, I guess, the UN had platformed a TB survivor, particularly from the global south. And I think that sort of that happened. The speech, the way I went about that. The way I went about approaching that speech, I remember, was that I felt that I should try and take inputs from the speech. Should not just be about me, but it should be a representative sort of a lot other people, a lot other TB survivors. So I remember reaching out to a lot of people I know, and in this and sort of dropping messages to TB survivors that I personally know as well, youngsters mostly, who were in their 20s. And I asked them as to what is it that exactly, could you like tell me what is the one thing that you feel people should know, or especially policymakers should hear about TB. And I think it was sort of, the speech was a culmination of a lot of such conversations that I had over the months, because I felt that I didn't want to make that speech just about myself and my suffering, and okay, no, this is okay, just make it about me and center it around me. But I
Right.
felt that it be sort of, if I am being given this platform, let it be a representative for a lot of other people. So I guess even the closing statement that I made over there was, I cannot hear you today, but I'll make sure you hear me. So I think it was definitely a very good experience. I never would have thought that I would be able to even speak or even reach the UN at any cost, because it's not like any of us come with existing social networks or existing networks of people that we knew, that okay, I could tap into some relative of mine and friend of mine and I can go and attend the UN. That was not at all the case for me. It just happened because I read about this high level meeting, and I happened to, out of absolute gutsiness that I showed back then, I guess I just shot off an email to a lady, Dr. Soumya Swaminathan, who was there at the UN back then, and I had marked a few more people, and I had just written to her about my work, and I said that okay, I would like to maybe give it a shot, that if I could maybe even attend the high level meeting, and if possible maybe given a chance. So it was just one email that I wrote. I absolutely, it was no way that okay, someone told me about it and I went through some person, or I knew someone. I didn't even know her back then. So it just happened that way, and I'm glad that that was one bit I felt, because that sort of set in motion for a lot of other. The next high level meeting happened. There have been, of course, changes to treatment that all of us have been involved in terms of pushing for better access to bedaquiline, better access to improved MDR-TB drugs, phasing out of injectables. So I guess a lot of the conversation also started during that period.
Thanks, Nandita. I think that that is absolutely incredible. And I actually remember reading that last line of yours, which you said that I may not be able to hear you, but I'll make sure that you hear me. So I think that that's really powerful. Ashna, what would be one of the advocacy efforts that you would like to share? The idea really, I think, again, on this platform is for and we do these conversations, and I always feel that the learnings are not just within that therapy area or that treatment area, right? So the learnings are for advocates across different conditions as well. So, yeah.
Thank you, Aparna. So I think for me, it was the gender responsive framework that India has come up with. So the first draft, when it came out, it was framed with some affected community consultation, but largely I think there was one trans person, and then the rest, everybody else was cishet, as far as we know. And we sort of wrote back with our with very specific, like sort of line by line inputs, because it was a very work in progress framework and it would have been very damaging if it had been implemented as is. So we did get a response from the ministry saying, could you, sort of tell us what else to do? And we're like, we're not the committee, so we can't tell you what to do. And so this sort of process went back and forth of advocating, and this was through Survivors Against TB, so we were all doing this collectively. We went back and forth. Eventually, the person who took charge of this framework, incredible bureaucrat and his consultant, they sort of sent this framework back to review again, because we suggested we should get this reviewed again by more consult, sort of representative set of people this time, including not just trans folks, but LGBTQI++, because gender and sexuality are interlinked. The framework doesn't address that, and you need to figure out, you need to understand that most of the social determinants that affect gender also mediate social, like sexuality. So they did send out the framework for written comments, and Survivors Against TB was part of that. So, and again, we told them that this is like, we're putting a band-aid on a bullet wound here, so we would suggest you reconvene a committee, you draft the framework. And they were very responsive. I mean, I had to eat my words because I thought this isn't going to go anywhere. It was such a learning experience for me that when you have somebody on the other side also actually believes in community engagement, which is a bureaucrat here in Festival and his consultant, fantastic folks. And the community collective, which is SCTV here, that sort of kept advocating in a very constructive way. It would have been very easy for, like, I think this went over 4 years. So it would have been quite easy to be disillusioned, but when you're sort of working together on something, I guess we also keep at it. And then they did sort of constitute a committee, and I was part of the core writing group. So it was someone from Reach, it was the consultant from CDB, and it was me. So and of course with inputs from everybody in the committee. Then we sort of redrafted this, and now we have a gender responsive care framework that's actually drafted by people from the affected community or people from the affected community, and has things like chosen family, which is unheard of in any document, because a lot of times when you have to go to next of kin or contact tracing with parents or spouse or whatever else, with LGBTQI folks, they may not have that backing. It may be chosen kin or chosen family.
Right.
So, yeah, that was a very good example of how communities can sort of bring about change in a sustained, it wasn't a revolution, it was reform, it was piecemeal, but also about how you can find and build alliances in the most unlikely places where you're not. I certainly wasn't expecting this from any government. It's not about my government particularly, but you know how they have this reputation.
Right.
We all sort of buy into these biases, but it was a very, very good example of sort of a collaboration between program and community. So.
And was it, I mean, I know that you persisted through, and that's, as you said, it took 4 years. So obviously you need to show commitment, you need to keep responding to requests and there'll be probably periods where they go quiet. But, were there any things that you did to keep that momentum for the 4 years or to keep the engagement going? And also, were you lucky that the bureaucrat didn't change during the 4 years?
I think it was a combination of both. It always is. Like even surviving TB, for that matter, it's luck is a huge factor. Luck, privilege. I mean, we talk, and then yeah. So definitely, what we did is whenever we were sort of asked to clarify something on the framework, we did. We were then for a period asked to train on the framework, and we refused. We said, which is when we said, we clearly said there's a problem with this framework. Why are trainings proceeding with this framework? And why are we being invited when we've specifically said there are problems? So, and then there was a very generative sort of engagement that how would you like this reviewed? And then we suggested that could we have this done? And so it was a very consultative process. It was not confrontational at all.
Right.
And then we sort of went in through this where we could engage people. It was definitely a combination of luck. And around that time, it wasn't just this. We were also talking about this through other means. We were publishing about it, we were speaking about it, it informs our work. We actually did interview people of the affected community during COVID. We managed to do this through the phone, where we got different people to talk about their experiences with the healthcare system, with TB, with HIV. And then and all of that work then informed these these semi-structured interviews with people. We transcribed it, coded it, got the themes from there. That then informed our advocacy. So we kept this sort of going, even though we weren't sure where we would go with it, but no knowledge is wasted. So yeah, we could go with that. The other sort of quick example is whenever programs typically talk about TB screening, it's always pulmonary screening. And we had this with a partner who was talking about doing this as part of their CSR work, and they kept saying TB screening, and so I clarified, and they're like, no, it's pulmonary, and I'm like, why aren't you screening for EPTB? And everybody in the room, including doctors, and this is why community lived experience is important, everybody in that room said, you can't screen for EPTB easily, you need like MRIs and CTs and this and that. I was like, well, sure, but in our country, like the disproportionate burden is lymph node TB, and if you can do a physical auscultation for most lymph nodes, which is a physical examination, or an FNAC, which you can do if you can do a blood draw in the field, you could actually screen for this particular variant at least. And I was given two arguments, which was that we can't possibly screen everyone, and two, we have limited resources. But interestingly, this was in hard to reach areas. And if you look at the studies, like there's an ICMR study that says 40% of EBDB cases become PTB. So like if you're going all the way there and you're not doing a comprehensive screen that will cost you nothing additional, then you're actually wasting resources because you might have to go back there again. So they did actually take that on board, and then all their forms changed to include symptoms of EPTB. Their communication changed. Like I saw the before and after just paintings on the wall that they do. And so then it was more comprehensive in terms of that screening, but that came from lived experience because I was an evidence. I didn't see myself in any of that. I didn't have any bloody cough. I had weight loss, sure, but over a period of 4 or 5 months, and I've never been above a particular weight. So even that didn't ring any bells for me. So yeah, these were two examples.
Thanks, Ashna. This year's focus, or even otherwise for the last few years, ending TB is been a big focus, and it's a priority not just globally but in India as well. We do have, the TB-free nation, or the TB Mukt Bharat initiative, but from a policy perspective, and I'm starting with you, Ashna, and then Nandita, you can add as well. What are the challenges that you are seeing on the ground, Ashna, and I know you've gone off video, so are you coming back? Yeah. So, what are the challenges that you would like to highlight in this conversation?
I think the first is we need globally and also nationally, we need more dedicated funding across the board. So for screening, for innovation, access to medication, community engagement, we need to invest more across the board and make sure we're really getting sort of value for our money here. So it's one thing to do a public awareness campaign, and that's fantastic. But if that's, for example, hypothetically, if that's all we end up doing in the name of ACSM, then we're not going to NTV with hashtags. It's very great to use social media as a tool. It's fantastic. We should use it. But again, then we have to look at, are we using behavior change science to inform our communication design? Are we using effective community experience to inform our communication results? Two is again,
I'll need you to speak up a little bit, Ashna.
Am I clear now? So
yeah.
Kilo fan.
I
Yeah.
think
Okay.
so
two is institutionalizing. I'm going to shout a little bit. Sorry to the viewers, but two is institutionalizing community engagement, because it happens in a sort of very tokenistic, after the fact kind of way, and also primarily in service delivery, which I have a huge problem with, because if you're not engaging them in decision making and policy, we're not hands for hire that are coming and sort of just do the service delivery part, right? So institutionalizing community engagement and decision making and service delivery, that's the second. And the third would be now, particularly when there's scarcity in public health, focusing on doing the basics really well. We like to get fancy, and that's okay. We can afford to get fancy if we have the time. But when we need to prioritize and we have a nation this large with these many people affected, we need to focus on reducing morbidity, mortality, making sure social protection is available, making sure community engagement remains funded and doesn't go on the shopping block as a book to have. So, thank you so much.
So Nandita, would you like to add anything from your perspective?
Yeah, definitely. So I'll pick it up from where Ashna said was that we'll have to focus on the basics, and that I think is really should be the one that we should be tackling. Simple things like, for instance, the government has a nutrition support, the 1,000 rupee nutrition support, but the coverage has been very weak. Especially in a lot of the North Indian states, for instance, Bihar, I read recently, the coverage has been just about 34 or 35% of TB patients have only received the mandated 1,000 rupee amount. So something like the service delivery definitely needs to improve. The access to CBNAT testing again, it has it gone up? Yes, definitely it has. But have we reached the optimum level? I don't think so. So definitely that is there. Bidaquilin, of course, Bidaquilin, thankfully, I think the coverage has improved compared to what it was, say in 2017 when the drug was first being introduced in the market. So definitely the coverage has improved, partly because of, I think a lot of credit is because of the fact that patients themselves are finding out about these newer drugs, and they are finding out and they are asking their health professionals as well, their health providers, as to, can we get the access to this medicine, can we do this, can we do something to make us feel better. So I think that is definitely there. Funding, 100% globally, we are seeing a lot of funding cut that is going on for not just TB but for across all infectious diseases. So we are speaking about a vaccine for TB that is in the pipeline. I'm hopeful something comes out, but looking at the state of funding, I'm not sure where that is headed. But certainly, I'm aware that the Gates Foundation is also trialing a vaccine for TB, and that seems to be amongst the most promising candidate right now. But meanwhile, I know that India has also been trying out a lot of BCG related. They are in sort of conducting vaccination drives around BCG, but none of them really are backed by scientific proof right now as to whether they are indeed effective, because the BCG is an extremely old vaccine that we have. So definitely an improved vaccine will help. Nutrition support, I think, is would be my number one, because that is something we do have in place, and we know that there is a rations trial that was conducted by Dr. Anurag and Madhavi Bhargava, which essentially told that food is the vaccine for TB, and
Yeah.
that was their biggest conclusion. So definitely, nutrition support has to go up, and it has to vastly improve.
Right, right. Thanks, Ashna and Nandita. Um, so, one of the things, Nandita, you're a journalist. And you talked of how you saw this newspaper article in the Mumbai Mirror. But do you think that TB gets the focus that it needs from the media, or do we really need to change the way communications plays a role in addressing awareness around TB? Even as I announced this discussion, when I was talking to a couple of people, they were like, "But why are you doing TB? Nobody gets TB, right?" So, and hardly any, it's not a big issue anymore. So, where do you think the challenge lies? And also, I would like to bring in the role of communications and stigma as well. So, Nandita, if we can start with you.
Yeah. I think I'll put it this way, that from my understanding is that compared to say 10 years back, I do personally feel that there has been a lot more coverage for TB. It has seen some improvement. Definitely, when I speak to journalists, I see, especially the people who do understand health and who do cover health, I see that their understanding of the disease has improved. For instance, they do take the effort to reach out to, say, a survivor. They do take an effort to reach out to multiple voices now, because I know that most journalists are really pressed for deadlines, and they are extremely hard pressed for time. But despite that, I do see people making an effort to reach out and sort of ask, okay, what do you think this is happening? And if they get the voice of someone from the government, they ensure that they also get a countering voice from the community. So I think that I feel was sorely lacking, I think, even a decade ago, because I guess community voices were also there here and there, but they were not very strong. So I think that has improved, but I guess also coverage is still largely, I believe, restricted to the fact that we speak during some of these big ticket days, okay, World TB Day, World AMR Day, and things like this. So I think these are, which a lot of the coverage is still restricted to some of these big days, which I'm not saying we should not be talking. We should be talking about TB during World TB Day, and AMR, we have to be discussing about TB. So any discussion of AMR is incomplete without discussing TB. So definitely that is there, but maybe a little bit more of a year round the clock or round the year coverage will certainly improve. I also feel for the fact that data availability also needs to improve. We do have a government's Nikshay portal that sort of gives some sort of data and understanding on what is the sort of incidences around TB, how many are being put into treatment. But a lot of the data also, I know, comes with a lag. The last TB report was also not released by the health minister. So there's been a lot of data availability gaps as well. So I guess that if the data is not available, I'm not sure what will a journalist also report on. So I think it has to be both ways. That we need sort of timely flood of data that is available for the disease, so that there is more robust understanding and also reporting about it. So definitely that is there. Of course, the contrast is very, I think, I just remember pointing out, I just remember thinking about this before our call itself, for the fact that, that we are seeing a lot of conversations, and rightly so, around, about the GLP-1 medicines, the
Mm,
fact that, obesity, weight loss, the medication, it's going to go off patent. And I know that there's a lot of buzz around it, media buzz about, the medicine is going to go off patent now. But I know that a lot of other diseases don't receive that similar sort of attention that is needed. Forget even obesity, but let's even put COVID versus TB. So to COVID, a lot of what was done during COVID was essentially repurposing the learnings that doctors found during TB, in terms of point of care diagnostics, in terms of, okay, how do we ensure patient care. But we all saw for the fact that uh, how COVID how we saw a flood of vaccines, and how we saw a flood of point of care diagnostics that came out during COVID. But it's been literally clawing to the straws when it comes to TB. So I guess that difference is definitely there.
right, right. And talking of COVID, I think I remember, Ashna, in our prior discussion, you were saying how COVID kind of crossed the barrier in terms of stigma. But because I guess such large numbers got COVID that it didn't seem to, that stigma kind of moved away. Whereas your view is that the stigma still kind of continues in TB. Ashna, do you want to talk a little bit on that?
Sure. I think with COVID, it was also because not just everybody, the global north got COVID. So it got it immediately.
Right.
It had TB years ago. It's no longer, it's apparently no longer their problem. But
Hmm.
of course it is. So yeah, I think the stigma persists. But I'm going to transition to that quickly, just with one addition to what Nandita said. Do you remember the polio ads, "Do boons zindagi ki"?
Hmm. Hmm.
And even if you take that, Amitabh Bachchan was there.
Yes,
Amitabh
Amitabh Bachchan was
and
the
he's also a
brand
TB
ambassador.
advocate. He also was
Yes,
speaking.
he's also a TB advocate. Yes.
But if you look at the communications behind the two, it's like "Do Boon Zindagi Ki" is like the super sophisticated thing, and our current comms, as well-meaning as it is, including for stigma, is just not there, because we can't just think of this in terms of punchlines. Sure, we want people to remember it, but we're not selling something. We're trying to drive behavior change. We're trying to drive increased awareness. And as if that does not inform our communications, if lived experience does not inform our communications, then we're going to keep seeing this gap that exists between where we should be and where we are. The stigma definitely still persists. I can tell you that even after you've completed treatment and people know you have TB, it's something that follows you around. It's not something that personally affects me. So I can claim to be very affected by it because I do not care, but that doesn't make it wrong that it happens. And I can afford not to care. It's not that I don't care because I'm brave. I don't care because I'm privileged. I don't care because I'm not financially dependent on anybody. I don't care because I won't be kicked out of my house. And worst case scenario, even if I am, I can find a place to stay. But so I can afford to be, unbothered by it. But people's lives are sort of wrecked by this. If women are married, families abandon them. If they're unmarried, the first question isn't, how will you survive this? It's who will marry you. We've had people ask us, like parents have reached out saying, my daughter has TB, do you think she'll get married? That's their first question. And I'm the first to ask this too, because that's not a concern for me. But yeah, so that stigma sort of persists, and it comes from all over. It can come from people, even people who are doctors. We have the nodal TB center here in Patna, and what we've heard is that non-TB doctors refuse to they're very hesitant to enter the DRTB ward and physically examine the patients. Right? There's self-stigma. I had a lot of that. What the form of TB I had was not infectious. It was lymph-node TB, and despite knowing better, I continued to feel like I will pass it on, even though I knew I won't pass it.
Right,
So
right.
it exists, and communication that says don't stigmatize doesn't help, because honestly,
Doesn't help.
I don't know why I shouldn't stigmatize. I'm thinking I'm doing this as infection control or to save my loved ones or myself or whatever else. So the communications around stigma also needs to get better. You need to explain that, hey, if you stigmatize, less people will disclose this. It will go underground, and then it will actually affect you. Your worst fear will become a self-fulfilling prophecy. So that public health messaging also needs to go out along with the rights-based messaging.
Thanks. I'm very conscious that we are kind of running into the the end of the time. A couple of last questions. One thing that I like, again, the people who come on the show, is if they have anybody that has inspired them as a patient advocate or as a community participation effort. Or it could be an effort that inspired you, and it can be local or global. So very quickly, Nandita, on that.
Maybe can Ashna go first? I'll just sip some
Sure.
water.
Sure.
I'm going to keep it very short. I
Yeah.
think the collective, and I'm disclosing my bias here, Survivors Against TB. They were just incredible how people can come together and work. I mean, all the people I've worked with, I've learned so much. DJ is one of our foremost advocates. Saurabh, Devshri, Trinity, Mansi, all of these folks, Sandhya, Devdu, and Chapal, who's the co-convener, Bashrata, who's sort of the heart and soul behind the comms and the advocacy of it all. I've seen, and it's not work to these people. It's like you have this tight-knit collective that's come together and sort of work on this. And I've just learned so much from there. So I think for me, that would be it. I was lucky enough to get to join them, and then that's how I started my work. I branched out eventually, but that'll always be fun.
Right. Thanks, Ashna.
I think definitely I'll say a couple of people. The one is MSF India was doing very good work in TB with all the limited resources that they had, especially their work in Mumbai around Bidaquilin, Delamanid, and especially serving the underserved communities in Mumbai was commendable. And they were, I think, really the pioneers, I feel, when it came to driving a lot of advocacy, community-based advocacy. I'll give them the credit for that, because I think what I felt they did was that they championed a lot of voices, even from across financial backgrounds. So, for
Right.
instance, another person I know, Meera Yadav. She comes from an extremely marginalized background financially, and she's gone through a lot when it comes to TB. But I think it was through MSF that she got a lot of support herself, because a lot of survivor groups, I feel, can get restricted to a certain strata of the society. But I think MSF was one group that I felt really, even when I met them, the work that they did in terms of the work that we did in terms of, filing that patent opposition, just to
Right.
give that we filed a patent opposition to sort of prevent a secondary patent on bedaquiline, because they were trying to extend their patent from the current 20 years to another 4 years. So I think that sort of advocacy wouldn't have happened had it not been for people, had they not had the conviction to actually go beyond just talking, to go and actually do some action. And I
Right.
felt that that was something that MSF has done multiple times, even in terms of, say, engaging with survivors, engaging with governments, and things like that. So I think that definitely I feel that the work that we have done on, when I say we, it is not just me and MSF. I think everyone, including Ashna, everyone, I think everyone has played their role in sort of championing the cause of improving medications for TB drugs. So I think that is something that I say definitely was played a very pivotal role. Again, I'll say the HIV movement globally had phenomenal work that they have done. I think a lot of people, including from the TB community, everywhere, they have taken a lot of inspiration and a lot of learnings from the HIV community, not just in India, but even in South Africa. So a lot of I think a lot of such movements, not just in India but even globally, sort of feed into the learnings that are in all of our work.
Absolutely. Yeah. I think, yeah, we always kind of cite some of these as examples to the people, the advocates that we work with. And very quickly, the last couple of points, there are often aspiring patient advocates or new people with lived experience who are trying to become patient advocates. Any advice for them, especially in terms of the learnings they need to focus on, and final closing comments as well? Ashna, you want to go first?
Nandita, do you want to take this? Sure.
Yes, I think I'll start with the fact that, it is one thing to, every advocacy essentially starts with, of course, speaking about your own experience is one thing. That itself is a big important step, no doubt, because it does take a lot of courage. It does take a lot of, internalizing some of our own hesitations that we have. Have to sort of overcome that to come and go vocal about our experiences. But there's a lot more to do beyond that, because nobody wants, I think, especially for aspiring, patient advocates, the last thing you would want is that you become a sort of a sob story, or, quote unquote, an inspiration pawn. That, okay, you're just sort of a placeholder material everywhere, that you're just called and you are given a chance to speak, and it's just good for the participant to make them feel nice about themselves. Oh wow, this person has gone through so much. And that happens very often in many places. This inspiration porn syndrome is very common, especially even when I started off. But if you have to cross that hurdle, and if you have to cross that, I think what is really important is the fact that you need to look at the bigger picture. If you are centering your experience, yes, that should be the foregrounding anchor. But you have to look at the bigger picture in terms of, say, what is the policy, what is working, what is not working, and what is happening globally, what are the learnings that we need to bring into the picture in India or anywhere. So sort of cross-sectoral learnings, cross-country learnings, and all of that can only happen if you sort of if anyone takes the effort to read, anyone takes the effort to keep themselves abreast with what is going on. Otherwise, you will be just left on the margins to just sort of becoming, okay, I'll just come and speak and everybody will clap, and then there is no value add beyond that. So I think definitely one has to patient advocates have to empower themselves with a lot more knowledge, with a lot more understanding of the scenario of not just TB, but even say other diseases. Because I was telling Aparna, I remember sometime before this call that one of the biggest comorbidities for TB is actually diabetes, and a doctor had told me about this. The sort of intersection between communicable and non-communicable diseases in India is very critical right now, because India's disease burden is sort of seeing a lot of transition from the communicable diseases, and also moving away from communicable to non-communicable diseases rising. But we still have the existence of these age-old diseases like TB. So some of this understanding can only come if we sort of have that cross theme and cross sectoral approach to our own understanding of the disease. So I think this is definitely one thing that advocates can do for themselves, to sort of look at the bigger picture, and to sort of be vocal about your understanding, and vocal about how you present your points across.
Right, right. Thanks, Nandita. Ashna?
Yeah. So I think just a couple of quick things from me. One, and this is borrowed from the great Gloria Steinem, in rooms where you have more privilege, listen, and in rooms where you have less privilege, make sure you speak up. But also, just sort of with the thing here is, I mean, I don't really think I'm able to give advice because we're all learning. But I would say that in any of these scenarios, sort of when you're advocating for better care, or you know, don't go in there thinking there's so much you don't know, because there is so much you don't know and you need to learn. But on your lived experience, you are the expert, and that lived experience is what informs policy. It is what informs care. So yeah, keep that in mind. This can get very, very depressing very quickly. So I mean, on one, like, finally, if at all I would call it advice, you're not going to end TB alone. We can all work towards that. But if that's your goal, you will wake up depressed tomorrow and not want to do anything. But if you can leave this better for even one person, help them find the nearest testing center, help them get medication, link them to nutrition support, even just that one person, and then you do nothing else. If each one of us can do this, that's fine. So yeah, very counterintuitively, don't aim to end TB, just aim to help the next person. And that's how we will end TB. So yeah.
I think I agree with Ashna that I think it all starts small, and you can just impact a few people around you also. That is good enough. Everything need not be at a very grand scale of things. It can just be about impacting a few people around us, and that itself counts as advocacy. Advocacy need not be about, okay, we have to go to the UN, we have to go here, we have to go there. It could just be about doing something within your own community, maybe going to a local school and talking about it, or going anywhere else, maybe at your workplace. It could be something as small and as simple as that, to sort of start shifting the needle.
Right, right. Thank you so much, both of you, Nandita and Ashna. I think a few key takeaways for me, just to wrap up, would be that I think number one is listening, right? I think we need to listen, because as both of you have said, while our own lived experience is important, it's not the sum total of what lived experiences are there. Number two, do what you can at the stage in life you can, right? There'll be times in your life you will be able to do more, and there'll be times you'll be able to do less. So, kind of plan. I mean, don't get disheartened if you can't do as the speakers here is represent India at WHO or the UN, but start small and things will snowball. Three, I think it's important to, when the opportunity comes up, work with policymakers, be proactive there, be supportive and constructive in that engagement, and kind of persist through that phase. And I think finally bring all of it together to use lived experience to shape policy. So I think those were my key takeaways from this conversation, and I'm sure there's many more. But thank you so much, Nandita and Ashna, for joining us today and for sharing your experience. And maybe all reduce TB if we can't end TB, one patient at a time. So thank you once again so much.
Thank you so much, Aparna. Thank you. It's been a lovely conversation. Thank you so much for everything that you do.
Thank you. Thank you.
Thank you, Aparna. Thank you for having both of us.